Okay, so you have a 26-year-old patient who's nulliparous, presents with vaginal discharge with odor. It's the third time she's had this in the past 9 months. Obviously, you're going to take a history and physical and do a physical. Tell me, what are you going to look for specifically as it might relate to this complaint?
So in terms of my history, I'd want to know a little bit more about when she's noticing the discharge. Does she noticing it after intercourse? Is she douching or using anything inside of the vagina? Is she using any new like soaps or detergents? If she had new sexual partners, is she using condoms with intercourse if she's sexually active? In terms of my physical exam, I would start with an external exam looking for erythema, erosions, excoriations. And then my speculum exam, I want to be really looking at the discharge, the consistency and color of the discharge, signs of cervicitis, like a friable cervix. I think that's what I would start with.
Okay. So you do all that evaluation. You do see some discharge in the vagina. The patient is sexually active. She is using condoms. When you do your evaluation, you notice the discharge appears whitish and a little bit thickened, if you will. So what would your workup consist of at this point?
So I would want to definitely test her for STIs given she's sexually active. In my practice, we have a gonorrhea and chlamydia swab that we use, and then a vaginitis panel that includes bacterial vaginosis, yeast, and trichomonas.
Okay. What is the, so you would check for all those, I assume, correct?
Yes, correct.
Okay. Okay. So let's say it comes back showing yeast. What are your criteria for recurrent yeast infections?
So recurrent yeast infection, I believe I have to double check to be sure, either 3 or more times in a year or greater than 3 times in a year. So she gonna say she meets criteria, but I would have to double check that.
Okay. What are risk factors for recurrent yeast?
So diabetes or uncontrolled glycemic control is a major risk factor. Some women are, we recommend wearing cotton underwear, not douching. Anyone with immunosuppression, you could be more concerned for yeast in as well. I think diabetes is one of the main things that we think about.
So diabetes, immunosuppression, and
hygiene.
Poor hygiene. Okay. So if you were suspicious that somebody may have a recurrent yeast infection, would that cause you to do any particular special testing as you're evaluating this patient?
You could think so. My vaginitis swab only looks for Candida, so there are other fungus or fungi that can cause yeast that may not be picked up on a vaginitis panel, that may not be treated adequately with treatment for like a generalized yeast infection. So sometimes if I have concern that patient's not being treated appropriately, I will actually call my lab and ask them to actually do a fungal culture to actually speciate the yeast as well.
Okay. So let's say that the yeast comes back, let's say it does come back as albicans. How would you go about treating this patient?
So for someone who's having recurrent yeast infections like this, you could do diflucan 3 times. So I would give her 150 milligrams and then tell her to repeat the dose 72 hours later and again 72 hours after that. And then sometimes that will clear the infection, but for women who continue to have recurrent infections, I would think about putting them on a weekly diflucan dose for like 3 to 6 months.
Okay, so I'm going to interrupt for a second. You said you would think about for 3, and then you 3 to 6 month it. So remember, they're picturing the patient as being right in front of you. So, the thinking about it should be either in your office or, behind the scenes before you tell the patient what you're going to recommend. I'm exaggerating this a little bit, but we don't want to use qualifiers. So, are you going to treat her for 3 months, or are you going to treat her for 6 months, or are you going to wait and see?
So I would start her on weekly diflucan. I would bring her back in 2 months and see how she's doing. And if she's feeling like much symptomatically improved, I would continue her on for 6 months.
Okay. Do you see the difference? Your first name's Natalie, right?
Yeah.
Okay. Do you see the difference in what you just said as compared to what you said before?
Yes.
Okay. It's more definitive. It's a little bit more methodical, makes kind of better sense in terms of, hey, this is a real treatment plan that, that somebody could get behind and understand what their responsibilities, meaning as the patient, what they are. And it makes sense. You're going to reevaluate her in 2 months instead of committing her necessarily to 6 months without. And if you did that, that would still be fine. But, this is good. And it's not wishy-washy, subject to the patient. It's pretty specific instruction. So I would say that's much better. All right. What lifestyle modifications would you suggest for a patient who has recurrent yeast?
So I would check an A1C to make sure that there wasn't underlying diabetes. But in terms of lifestyle modifications, I advise my patients to wear cotton underwear. I advise them to change out of wet clothing or wet bathing suits as soon as possible. I do not recommend douching or putting anything inside the vagina, just cleaning with a gentle soap like Dove externally. And I think those are the basics.
Okay. So let me change it slightly. Let's say when you ask for the speciation of the yeast, it comes back showing, let's say glabrata.
Mm-hmm.
So not sensitive to your fluconazole. How would you treat her, or what would you recommend at that point?
I would recommend boric acid, but I would have to look that one up.
Okay.
The treatment, dosing, and course.
Okay. All right. Very good. Nice job. Let's go over this one. So the definition that I'm familiar with is 4 or more or greater than 3 in 12 months. Some people also
I couldn't remember if it was greater than 3 or included 3.
Some people use more than 3 in 6 months. I've seen it written both ways, so I think either you're probably okay. Let's see. I thought your history was good. You mentioned diabetes, so risk factors for recurrent yeast. So diabetes would certainly be one. You mentioned poor hygiene. That's true, of course. Immunosuppression. So a patient that's HIV positive is immunocompromised in any other way, so maybe receiving steroids or has had a transplant or something like that, certainly would be at increased risk, as would patients who are pregnant. Obese patients are going to have an increased risk. Patients who are on birth control pills technically can have an increased risk of yeast infection. Certainly recent antibiotic use or chronic antibiotic use also can predispose somebody to recurrent yeast. I'm sure there's others. Those are the ones that come to mind. So the key thing here is, again, the checking the particular type of yeast species. Again, if you identify a yeast infection, because, if it is one of the less or more atypical, like tropicalis or glabrata, it may or may not be susceptible to what we would typically use, which would be diflucan. Or I shouldn't say typical, but commonly uses diflucan, or at least commonly requested. So the 150 for 3 doses every 3 days, I thought was good. Your weekly is good. 4-6 months is kind of a common treatment, but I thought your caveat of the 2 months and see how she's doing. I mean, no sense keeping somebody on for 6 months if they're not responding well. So I thought that was good. You mentioned an A1C. My only comment here would be I would add in an HIV test if they haven't had it.
Okay.
Your cotton underwear, no wet clothes, no douching. So what type of vaginal infection do we typically more associate with douching?
More associated with BV.
Right, exactly, because it's going to upset the acid-base balance of the vaginal ecosystem. So, yeah, I think those lifestyle modifications, no tight jeans, no stockings, perhaps not sleeping with any undergarment at night. Again, all about trying to reduce the moisture content in the vulvar area. And then your boric acid suppositories, that is actually what I was looking for. They're once a day. I want to say they're 600 milligrams intravaginally. I'm not 100% on the dose though, guys. And I would suggest if you ever do prescribe them, please forewarn your patient if they have any young children at home. They're extremely toxic if consumed orally. I think that's it for recurrent yeast infections. Do you have any questions?
No, I think that's great. Thank you. That's helpful.
Nice job. Thank you. By the way, guys, we will stop at about 10 of 10, and I'll try to go over any questions that folks have. You can either write them in the question box, or I'll take people off mute at that time too. So if you want to ask, you can ask then. Okay, so any of the other doctors that I had initially called on the nobody? All right, let's go back to our list. So let's see, we called Dr. Freeman and we called Dr. Della Valle, Dr. Vizquera, Dr. Islam, or Dr. Kesar. Any of you three on? Oh, Dr. Islam, good. Dr. Vizquera, Dr. Kasem. Wow, I'm 3 for 3. This is like so unheard of considering my last week I was striking out. Dr. Islam, I'm going to take you off mute. It says, there you go. Hi.
Hi.
Are you a generalist or are you a subspecialist?
Subspecialist in MIGS.
In MIGS. Okay. Sorry. Okay. Let's see. So you have a 25-year-old G3P2 with a history of C-section ×2. She comes to see you for new OB at 8 weeks, and she's found to have a cesarean scar pregnancy, at least by your initial ultrasound. So what would you do with her? Tell me how you would manage this.
So ideally with a patient that has a cesarean scar pregnancy, I would want to evaluate the patient immediately. I would be concerned for a potential, ruptured cesarean scar pregnancy. First, I would want to make sure that she's stable, check on symptoms, vaginal bleeding, pelvic pain. I would want to review what the reasons for her previous cesarean deliveries were and take a look at the ultrasound, particularly where it's specifically located. I would want to assess whether or not the pregnancy is in the niche or above the scar or underneath the scar.
Dr. Islam?
Yeah.
I'm sorry to interrupt. Does it make a difference what the indications were for her previous C-section?
No, it doesn't for management, but it would help me determine if I should anticipate a difficult surgery if surgical intervention is necessary.
Well, how would that help you anticipate an easier or more difficult surgery?
Depending on whether or not she had a fan and steel incision or if she's had a history of a classical cesarean, if it was an emergent cesarean versus a planned cesarean, I think that would help determine whether or not there's a risk of adhesions, and maybe even look at entry if I needed to do a laparoscopic procedure.
I mean, wouldn't you have, with 2 prior C-sections, wouldn't you have to be prepared for adhesions in the first place?
Yes, lower uterine segment adhesions are definitely likely, but if for any reason she had a classical cesarean, that would increase the risk of even more significant adhesions, especially to the anterior abdominal wall.
Okay. So, all right. So tell me again, obviously the history in terms of the indication for the C-sections, or at least the type of C-section they had. And I'm sorry, can you tell me what else you said?
Reassess the ultrasound to see exactly where this pregnancy is, because it can be in the niche itself, or it could be underneath, lower in the scar. And of course, I would want to get laboratory evaluation too, check a CBC, CMP, and
What are you looking for with the CBC and the CMP?
making sure that she's not anemic, checking her platelets. CMP, I would want to evaluate for in case, for any reason, medical management is decided on, like methotrexate therapy.
Okay. Well, let's say, again, all you see from the ultrasound is it's in the cesarean scar. You can't really discern much more than that. It is 8 weeks. There is a positive fetal heartbeat. So, what else are you going to do? How are you going to manage it?
I would recommend that this patient probably consider.
Probably consider.
I would recommend surgical intervention for this patient. If cesarean scar pregnancy can be catastrophic.
Mic off.
It could cause uterine rupture. It could cause rupture ectopic pregnancy. So I would recommend laparoscopic, removal of the cesarean scar pregnancy.
Laparoscopically. Now, you had mentioned methotrexate. Can you give methotrexate to a patient like this?
In my practice, I would recommend surgery rather than methotrexate, although it's something that may be considered. My understanding is that the success rate for treatment for a cesarean scar pregnancy is less likely.
Okay. So what would you do surgically for this patient?
First, I would want to make sure that I notify my team. I would want to let anesthesiology know and make sure that there's a massive transfusion protocol in place in case there's significant hemorrhaging. For the particular case, I would want to make sure that I have adequate assistance in case I need additional help, if I needed GYN oncology available. But for this particular laparoscopic procedure, I would want to make sure that we have adequate ability to obtain hemostasis. First, I would want to utilize vasopressin at the site to vasoconstrict any vessels in the area. And then I would want to make sure that there's appropriate vessel sealer and suturing material. And I would want to make sure that there's TXA as a hemostatic agent in case that's necessary to give preoperatively or before we start the case, and approach it by first injecting vasopressin in and around the area and then dissecting off adhesions down to the lower uterine segment, past creating the bladder flap, and then making sure that we excise the pregnancy around the cesarean scar, and then suture that area with delayed absorbable barb suture.
Okay. What about approaching this vaginally?
Hysteroscopically, it can be attempted as well, and so that is an option that can be considered. I think it would depend on the location if it's lower down underneath the scar itself. But in my experience, I would prefer the laparoscopic approach.
Okay. What if the patient said to you, "Hey, doc, I appreciate what you're telling me, but I want to have this child." What would you do in that case?
I would make sure that I get maternal fetal medicine involved and co-manage this patient. I would counsel her on the increased risk of rupture, pregnancy complications, and potential for an emergency to occur. I'd want to closely monitor this patient and make sure that she's not having any symptoms of pain, bleeding, and ultimately, if this pregnancy does get to further along in the pregnancy into the third trimester, I would assume that delivery would be earlier, much earlier, probably around 34 weeks, 32 to 34 weeks.
Okay. How would you counsel her? Let's say she is amenable to terminating the pregnancy, and by the way, she has undesired fertility at this point. Would hysterectomy be an option for her?
If assuming that this patient is still 25 years old, I would counsel the patient on multiple options. Hysterectomy, of course, is something that I would always, discuss with the patient. I would potentially recommend against, especially if I discuss with the patient whether or not she desires any future fertility, or I would talk to her about the risk of regret if she were to have a definitive therapy with hysterectomy at such a young age. But again, this would be a shared decision-making process and with informed consent. If the patient truly does want a hysterectomy at this time, I would.
Would you present it as an option for her?
I would talk to her about that as an option, yes. She's had 2 previous deliveries. This is now a cesarean scar pregnancy. The risk of that happening again in the future is higher. She's at risk of placenta previa spectrum.
How high is it?
It's higher than the specific percentage. I would have to look up, but I would discuss with the patient that the risk is high.
Okay. Have any idea what the incidence of cesarean scar pregnancies is in the population?
I would have to look that up.
Okay. Anything else you want to tell me? And don't be mean.
Don't be mean, no.
Okay.
No, I think I'm good.
I didn't mean to cut you off. If you have something else you want to say, please, by all means.
Nope. I think I'm good.
All right. Very good. Nice job. So let's go over this one. So the incidence of cesarean scar pregnancy is about 1 in 1,800 to 1 in 2,500. So fairly uncommon. So you do want to tell your patient that, you do want to recommend against expectant management. Again, not to say that obviously we're not going to take the patient against her wishes and terminate the pregnancy, but she is at super high risk of having complications from this, including, as you said, placenta previa spectrum, postpartum hemorrhage. The morbidity and even mortality can be quite high for this condition. So it is something that she needs to understand and give serious consideration. Methotrexate alone, unless you're going to give it intragestationally, is not recommended. So, unlike a tubal ectopic, we would not just give this patient methotrexate by itself. Pardon me. Again, unless we do it into the sac. Obviously, expectant management is fine if the patient has a non-viable pregnancy, so there's no fetal heartbeat, what have you. Different ways to treat this would include either laparoscopic, as Mohammed told us. transvaginal or ultrasound-guided uterine aspiration. A curettage alone is not recommended. So you could do, you could try to remove this again with ultrasound guidance. Uterine artery embolization could certainly be considered with a DNC and hysteroscopy. There is a 90+% success rate with that. Hysterectomy would be a very viable option if the patient has completed childbearing. So, you know, we're always like, you know, we want to be super conservative and this, that, and the other, especially for board purposes. But in this case would be very reasonable, again, if the patient has concluded her fertility to talk to her about hysterectomy being an option. Certainly, probably a safer option than some of the other procedures. She does have a high risk of recurrence. It's as high as 40%. It ranges, depending what you read, between 5 and 40%. And then, let's see, what else are we going to tell you guys about this? Oh, if she does choose expectant management, again, you would want to counsel her regarding the risks of uterine rupture, abnormal placentation, postpartum hemorrhage, and even maternal death. You would want to deliver the patient electively by C-section, of course, between 34 and 35 and 6 days. So I think Mohammed was talking about doing a excision for the of the pregnancy laparoscopically. Again, that is a viable option, but if you're going to do that, you know, you may want to look at the extent of the whole C-section, the scar, if you will, and potentially revise the entire scar. Again, if you're able to and you're doing it laparoscopically. Mohammed, do you have any questions for me?
Only if you think that the thought process was appropriate with the questioning that you were giving. I think one thing that I was second guessing on was that these types of patients can, you know, potentially carry to preterm. And so I don't know if they wanted us to talk about the specific location of where the C-section pregnancy is, talking about like the niche versus not, like those types of things.
I wouldn't start off honestly with that level of detail. I would treat it more as a general condition personally, in terms of talking about cesarean scar pregnancy. You know, I think the key things to mention here is that you would advise against carrying the pregnancy or continuing the pregnancy, you know, and explain to the patient. And again, the morbidity and mortality is really high. I'm not saying there's more than a 50% death rate, but certainly morbidity, there's more than 50%. I don't recall the number specifically. So you would want to explain that to the patient, which is why you're not recommending that she continue the pregnancy. And you need to forewarn her again about the recurrence risk. It's not that it's 100%, but it certainly is elevated. So, you know, and the key thing is not just going in and doing a DNC or not just putting her on methotrexate. Those are two important no-nos. So I think the rest of it, and you didn't say that for either. So I think the rest of it is fine. Does that answer your question?
Yeah, thank you.
Thank you. All right, sir. Moving along, let's see. We have Dr. Biscara. So I'm going to take you off mute. It says you're self-muted. So if you want to take yourself off, that would be great.
Hi.
How are you?
I'm well. How are you?
I'm doing well, thank you. Are you a generalist or specialist?
Generalist.
A generalist. Okay. So let's see. What do we want to ask you about? Okay. So let's see. You do a C-section on a patient for a brow presentation. She develops a broad ligament hematoma. Before we get into the broad ligament hematoma and your management thereof, how would you manage her if she came in labor and was a brow presentation? What would you do with her?
Well, I would, of course, see her, put her on the monitor and ensure that baby's doing well. I would see if she's in labor, is she having contractions, and then immediately put an ultrasound on to see if if she's mentum anterior or posterior.
So do we usually refer to brows as mentum anterior and posterior?
No.
Okay, so why are you gonna, what's the purpose of that?
Just to know like where the position. Well, I would want to know where the chin is
Why?
located. Because if the chin or the mentum is anterior, you can actually still proceed with vaginal delivery.
In a brow presentation?
No, sorry, I was talking about mentum.
So what are we gonna do?
So for brow presentation,
Devin,
oh,
go ahead.
sorry.
I was gonna say, let's just say she's a G2P1, she's a term, she's 7 centimeters.
Yes. Okay. So they can still convert to a presentation that allows for vaginal delivery. But most so we can still continue depending on how baby is tolerating labor at that time.
Okay, so let's assume the tracing looks fine. And she is, you said the baby could convert to a presentation allowing a vaginal delivery. So what are the different options that could happen as far as the baby goes?
They can, the neck can extend further and lead to a mentum anterior face presentation. It could flex and be OP. And rarely it can convert to OA.
All right, so it could convert to a face or a vertex is what you're saying, is that right?
Yes.
Or could it persist as brow?
Yes, it can persist as brow, and in that case, likely a cesarean delivery would be indicated.
Okay, so any idea how likely it is to stay as a brow?
I would say about 50%.
Okay. What about how likely is it to go to vertex?
To vertex, about I would say maybe 20 to 30%.
Okay, and I guess the other 20 to 30 would go to face, right?
Yes.
Okay. Can face deliver vaginally?
Again, only if it's mentum anterior.
Why not if it's mentum posterior?
Because if it's mentum posterior, sorry, I'm trying to basically the head cannot flex further in order to allow for a vaginal delivery.
Okay. Hang on one second. Okay. What about obviously vertex is straightforward. And you said a brow, if it persists as a brow, yay or nay on the vaginal delivery?
It's likely there will be a dystocia, and I would go to C-section.
Okay, so before the dystocia, you'd go to a C-section. Is that right?
Mm-hmm.
Okay. All right. So, and that wasn't even the gist of the question. So you do a C-section because the brow persists, and you see that the patient is developing a broad ligament hematoma. What are you going to do?
So when I noticed that there's a broad ligament hematoma, I'm sorry, is this before or after delivery? We already did the delivery, correct?
So it
Oh.
says you do a C-section on a patient for brow presentation. So you do a C-section and you develop a broad ligament hematoma. So what I'm getting at here is, first of all, from a technique standpoint, if you're unsure or the question's vague, just predicate your answer on your interpretation of the question.
Okay.
You know what I mean? So assuming I've got the baby out and she's developed a broad ligament hematoma, or if this is before I made my hysterotomy incision, which would be kind of weird, but whatever, and they'll just redirect you if they don't like the direction you took. Does that make sense?
Yes.
Okay. So this is after you've made the incision. You go to deliver the baby comes out, and you discover you have a developing broad ligament hematoma.
So I would place a direct compression along the area that is developing the hematoma, and then take a look and see if the compression does stop the expansion.
How long would you hold it?
I mean, not too long, just maybe like 10 seconds, just to make sure that I have the correct location. And then I would also then exteriorize the uterus if it's not already exteriorized, to help decrease the blood flow into that area as well.
Okay. So you're only going to hold it for 10 seconds. I mean, do you think that's adequate time to stop the bleeding?
No, it's I guess that was just to make sure that I had the correct area, and if I did, then I would hold it longer. And I don't know. In a C-section study, I'd probably like a minute, and then if it was not,
You
and then
broke
if
up.
sorry, like about a minute or so, and then if I let go and there was still bleeding, then at that point I would move on to other means of controlling the uterine artery bleeding, or the bleeding at the broad ligament.
So I'm sorry, I still missed how long you would hold it.
A minute.
Okay. All right. So after a minute, it seems to still be expanding.
Mm-hmm. So then in that case, I would ligate. I would attempt a uterine artery ligation, or I would do a uterine artery ligation.
What's the purpose of a uterine artery ligation?
It's to basically the cause of the broad ligament hematoma is likely because of injury to the uterine artery. So if you ligate that, then you could also decrease the amount of bleeding and stop that hematoma from expanding.
Okay. What if you discover that the hematoma is expanding rapidly and it's heading toward the retroperitoneum?
I mean, I would, and this is after I already did the uterine artery ligation. Then I would assess it again. I would I would apply pressure again in that same area, since I was able to stop that with the pressure, and then take a look. And I would again just try to see if if I actually did ligate the uterine artery, by just taking a closer look at the area and try to and add additional sutures in that location. And if it was still continuing to expand, at that point, I would be considering hysterectomy.
Okay. All right, let's talk about this one. So, decent job on the malpresentation. So you're right. If the patient is brow, in about half the cases, they'll persist as a brow. About 20% will convert to vertex, and about 30% will convert to face. And you were also correct when you said mentum posterior cannot deliver vaginally. And the reason they can't is because the neck is fully extended. So it can't negotiate the pelvic curvature. Not to mention the presenting part is going to be chin to occiput versus biparietal diameter. So the diameter is going to be more, but mostly it's because the neck is fully extended. All right, so face presentation, mentum posterior has to have a C-section. Mentum anterior could conceivably deliver vaginally, but you have to let mom know that there's apt to be a fair amount of bruising about the baby's face. She may not want that, but either way, you should let her know before she delivers, because otherwise she's going to freak out when she sees, potentially, when she sees the baby. Brow presentation theoretically can deliver from below. I would do the same thing in terms of that Nika said, in terms of doing a C-section if she gets to fully dilate and she's still brow. And the reason is if she starts pushing and she gets stuck at +1 to +2, either stuck or let's say there's distress, obviously there's no instrument delivery we could perform even if she was +2. So we lose that option, and it's going to be a basically a deeply impacted fetal head because there's not much to grab onto without poking the kid in the eye or what have you to elevate the head to deliver it. So, including having the nurse push from below. So, be at high risk for extensions inferiorly into the cervix and potentially into the vagina. So, if she got to fully and she hadn't converted as a face, again, I'm not saying you absolutely I'm sorry, not as a face, as a brow. I'm not saying you absolutely have to do a C-section, but I think most generalists would, and I think a case can be made for it, again, because of the what if. If everything goes well and she delivers vaginally, well, you know, of course she delivered vaginally. But if it doesn't, it's going to be a holy nightmare. Okay, so the hematoma, the key thing here is when you have a hematoma, whether it's a vulvar hematoma, whether it's a broad ligament hematoma, you want to apply pressure, but you need to hold pressure for a good 10 minutes. Bleeding times can take up to 9 minutes. So you want to hold direct, firm pressure on this, again, for a good 10 minutes. You want to see if it's expanding. If it's expanding slowly, it's probably a venous bleed. If it's expanding rapidly, you have to be concerned that there is an arterial bleed. So Nika was correct. You would want to do a uterine artery ligation. The idea behind uterine artery ligations, at least in the presence of postpartum hemorrhage, is to decrease the pulse pressure and allow the clotting factors to set up. You could certainly do one ligation, like an O'Leary stitch. You could go up a little bit higher along the uterus as well and try to tie it off again. But all the while you're going to be holding pressure, which again is less likely to work in an arterial bleed, but not impossible. If it starts to expand into the retroperitoneum, what's recommended is that you call in either a GYN oncologist or a vascular surgeon with experience in the retroperitoneal area, and that we should not open it ourselves and start digging through trying to find the bleeding vessel. Excuse me. So again, you would continue to hold pressure. You could certainly give your TXA. I'm not sure how well it's going to work, but certainly would be reasonable to do that. Depending on the vessel, the hysterectomy may or may not help. Obviously, you're clamping the uterines, etc. But if this is starting to dissect into the retroperitoneum, we don't know where the bleeding vessel is, and it could have retracted. So, Nika, any questions about this one?
No, it's good. Thank you.
Sure. Things we hope we never see in in the operating room. Okay, so let's see. I don't think anybody else raised their hand of people I asked before, but let me just double check. Dr. Kesar, there you are. I'm trying to get you off mute. Dr. Kesar?
Yeah, I'm off. I'm here.
Great. Are you a generalist or specialist?
I'm a generalist.
Okay, let's see what we can bother you about tonight. Patient, let's see. So patient is a 48-year-old G3P3 with abnormal uterine bleeding, failed medical management. She had a benign endometrial biopsy, had a DNC hysteroscopy, and an endometrial ablation showing benign endometrium. So first of all, what's the Palm-Cohen nomenclature for abnormal uterine bleeding?
The Palm-Cohen nomenclature is to know the etiology of AUB, and then in that you have the structural causes and the non-structural causes. The structural causes being polyps, adenomyosis, leiomyoma, malignancy, and the non-structural causes would be coagulopathy, anovulatory bleeding, any endometrial hyperplasia, iatrogenic causes, and non-specific. Mm-hmm.
So the E is endometrial, you said?
E is, yes, E is endometrial, if I remember correctly.
Okay. And under the endometrial, I thought I heard you say hyperplasia. Is that correct?
Yes.
Okay. So what about, so is that benign endometrial hyperplasia, or is that EIN, or both?
So the endometrial hyperplasia, I mean, can be benign or the EIN, but I believe the EIN comes under the malignancy M, if I'm not mistaken.
Okay, so why would the EIN go under malignancy and the other one go under endometrial?
There is a high risk of EIN is considered a precancerous lesion with a risk of almost 50% of conversion to endometrial cancer. And that is the reason that it would be, I probably am overthinking. I would consider endometrial hyperplasia both benign and EIN under E.
Under E, okay.
Yeah, I might be overthinking, or I just have to look at it again.
Okay, so you said 50% of EIN will convert to cancer?
There is a high risk of EIN progressing to cancer, because when in an EIN, if they proceed to have a hysterectomy, and in the hysterectomy specimen, almost close to 50%, there is a finding of an endometrial cancer.
Okay. Okay. So anything else you can think of that might go under E other than hyperplasia?
Sorry, I'm blanking out.
Okay. So she failed medical management. What medical management would you typically try for a 48-year-old like this? Obviously, it's going to be dependent on, you know, whether she has contraindications for certain medications, but in general, let's assume she's otherwise healthy.
So the medical management that I would discuss to her about would be scheduled non-steroidal medications, like non-steroidal anti-inflammatory medications, then hormonal options such as oral contraceptive pills, the progesterone-only options such as the Depo-Provera, also the hormonal IUD, such as the levonorgestrel IV. And I can also discuss with her the other hormonal options, such as GnRH analogs, either the agonists or the antagonists.
So, what's the mechanism of action of NSAIDs?
So NSAIDs, they inhibit the prostaglandin pathway. I believe it's the prostaglandin F2 alpha, or just the prostaglandin pathway, and that's how they decrease the volume of the amount of bleeding, and they cause improvement in the dysmenorrhea as well if it is associated with the AUB. And that's how we have an improvement in symptoms as well as anemia.
So, this patient ended up having an endometrial ablation. So,
Yes.
When you do an endometrial ablation, do you ensure that the patient is using some form of permanent contraception?
Yes, I do discuss to the patient about some form of contraception prior to the procedure. And the reason being, with an endometrial ablation, if there is a pregnancy in the future, then there is a risk of either abnormal placentation or a pregnancy loss.
Okay.
Mm-hmm.
Endometrial ablations, what percentage of patients have state that they have improvement or are satisfied with the procedure after they have it?
So following an endometrial ablation, around roughly 30% of the patients will achieve symptomatic improvement, either in the form of amenorrhea, and around 30% will have decreased in the amount of menstrual blood loss. So I would say 30% of amenorrhea and 30. Mm-hmm.
I'm sorry, 30% of amenorrhea and 30% decreased?
Yeah, decreased frequency of menses and the volume of menses.
So are we talking about 60% overall then?
I will have to check those numbers again, but I believe it's 1/3 of the population will have, and 1/3 of the patients will have improvement in the form of amenorrhea, yes, and 1/3 of them will have decreased in the volume and the frequency of menses.
So, okay, what anatomic factors reduce the effectiveness of an ablation?
Definitely the things I would consider before an endometrial ablation would be the uterine size, the presence of a uterine fibroid, especially the size of the uterine fibroid. Also, when I talk about the uterine size, also consider the width and the length of the cavity. The other things I take into consideration are if she has had any prior classical cesarean sections, which would cause filling of that area of the scar, and also like I mentioned earlier, the size of the leiomyoma.
Okay. All right, I think we will stop there. So, all right. So Palm Cohen. So the endometrial hyperplasias would go under the malignancy.
Yes.
And if you think about it, it kind of makes sense. Think about it this way. You know, as you said, the palm is structural. So you could hold a polyp in your hand. You could hold a fibroid in your hand. You could hold a uterine cancer in your hand. You can't hold an ovulatory event in your hand. or an anovulatory event in your hand. You can't hold a hormone in your hand, so to speak.
Mhm.
But you could hold a DNC specimen that had EIN, and you could hold even benign endometrial hyperplasia specimen in your hand. That's a physical specimen. So in any case, it would fall under malignancy, albeit you're right, the chances for malignancy in benign hyperplasia are quite small. So what we would think of for E would be like an endometritis, either atrophic or infectious, would be an example for an E. Your chances you mentioned of progressing to cancer. So there's a 40% chance with somebody with EIN of already having cancer, and the chance of progression if they don't is about 25 to 30%. Now,
Okay.
you did mention several medications. So NSAIDs are going to be cyclooxygenase inhibitors.
Mhm.
So it's going to interrupt prostaglandin cascade, the cycle,
Right.
with less prostaglandin formation. Concerns about pregnancy with patients with ablations. So, as a general rule, you want to make sure the patient herself has either had permanent sterilization, her partner's been sterilized, or she's at least using some reliable form of contraception. If the patient gets pregnant, there's a risk, as you mentioned, of abnormal placentation, certainly miscarriage, growth restriction. There have even been, albeit few, but the reported cases of uterine rupture. So there is even a risk of maternal mortality. So it's really important to make sure that the patient is using reliable contraception. In terms of improvement, about 80 to 90% of patients will report improvement in their menses. Up to 40% will have amenorrhea after year 1, and up to 50% between years 2 and 5. A little bit of it depends on the instrument used to ablate them, but certainly size of the cavity would be could affect the success rate. You mentioned fibroids, I would agree. Polyps would be another thing. And then if the patient had adenomyosis, that would be another thing that could reduce the effectiveness of an ablation. I'm not familiar with a prior classical as being a risk for failure, but certainly if anyone else knows, they can feel free to chime in, which we'll go over at the end. Do you have any questions for me?
I just wanted to know the percentages of improvement after ablation. You said amenorrhea was 40%, and I'm sorry, I just. Do you mind repeating that again? Yeah.
80 to 90% of patients are either satisfied or report improvement in their bleeding.
Oh, I see. Okay. Okay.
It's pretty
right.
high.
Okay. All right. Thank you.
Thank you.
Mhm.
Okay, so I'm going to make one scroll through here real quick, see if anybody else I had called on has. Okay, so let's get some more folks. Looking for Dr. Rondinelli or Schleiser. Either of you are on, please raise your hand. Dr. Rondinelli. There you go. It says you're self-muted.
Hello.
Hi, how are you?
Good, thanks. How are you tonight?
I'm doing great. Thank you for
Good.
asking. Let's see. Have we covered osteoporosis?
I believe it might have been earlier in the month. I haven't personally, but I think it has been discussed at some point.
Okay. Let's do it anyway. It's a frequent flyer.
Okay, that's good. I have it on my case list too, so.
Because you guys don't get to do enough menopausal medicine in general.
No.
Okay, so in a second, you'll see the screen. So, 58-year-old postmenopausal woman comes in for a well woman. How and when would you get a DEXA scan? So, when, obviously, and under what circumstances would you get a DEXA? The when is probably sufficient.
So typically I start DEXA screening at 65. However, in the case of a 58-year-old postmenopausal female, I would consider other high-risk factors in order to calculate a FRAX score to see if she would qualify for getting an earlier DEXA screen.
What would you be looking for in that FRAX score? So what
So I'm
number?
looking, the number, it would be the risk of a hip fracture or major osteoporotic fracture, I believe, in the next 5 years.
And how would you calculate that?
So I use the FRAX scoring calculator by inputting a number of questions or risk factors in order to get that score.
Okay, is there a particular number you look for?
So for major osteoporotic fractures, it would be more than 20% risk. And for hip, it would be greater than 3% risk.
Okay. So what's the difference between a T-score and a Z-score?
So T-score is the average bone density in an age-matched patient of the same ethnicity.
I'm sorry,
And then,
which one was that? A T or Z?
that's the Z-score. The T-score is a patient who is a young, healthy, white female.
How young?
I'm going to guess a patient in her 20s.
Okay. Which one would you use primarily for this 58-year-old?
In a 58-year-old postmenopausal, I would use the Z-score. The T-score.
Okay. So let's say you decide to get a DEXA on this patient earlier, and her T-score comes back as minus 1.9. What would you do?
So with a T-score of minus 1.9, that would be in the osteopenic range. And so I would be looking at her, then I would be looking at her FRAX score to be determining whether medical management would be warranted at that time. I'd also be counseling the patient regarding lifestyle and diet modifications to decrease her risk of osteoporosis if she doesn't qualify for treatments. But even if she does, I would be discussing vitamin D, calcium. Also, I understand protein intake is also a recently identified important factor, and lifestyle modifications such as increasing weight-bearing exercises.
Okay. How much calcium and vitamin D would you recommend?
For calcium, I would be recommending around 1,000 to 200 milligrams per day, and I always encourage patient to supplement diet rather than taking
Sorry, you said 1,000 to 200?
1,000 to 1,200. Sorry, 1,000 to 1,200.
Okay.
And then for vitamin D, I recommend 600. No, sorry, 6 to 800 international units per day.
Okay. So this patient with the minus 1.9, you said you're going to calculate a FRAX score on her, is that right?
Yeah, I would use the FRAX score to determine whether she needs medical treatment.
Okay, so you plug her back in with her T-score, and what numbers are you looking for now?
Now I'd be looking at those numbers that I mentioned earlier.
Oh, so you're looking at those numbers with and without a T-score?
Well, if the T-score is in the osteopenic range, then those numbers will determine whether I'm going to manage with medications and treat her as an osteoporosis.
Well, how are you going to decide if the patient gets an early DEXA?
It is a calculation, but now I'm trying to think if it's a risk calculator, but I'm trying to remember what the output of the risk calculator is.
Okay. So let's say she does qualify for treatment. What would you recommend?
So my initial medical management would be with a bisphosphonate. That would be my first line unless there's contraindications to taking that medication.
All right. So first of all, how do they work, bisphosphonates?
Bisphosphonates decrease osteoclast activity.
Okay. And you mentioned contraindications. What would be contraindications?
A disorder that would inhibit the patient's ability to swallow appropriately. So one example would be achalasia. If she had peptic ulcer disease, or if the patient had mobility issues or postural issues where she wouldn't be able to sit up for 30 minutes after taking the medication.
Okay. Would you ever use a Z-score on a patient?
The only time I would use a Z-score is if I, for some reason, had to evaluate for osteoporosis in a patient who was under the age of 40.
Okay. Last question. If you put a patient on a bisphosphonate, when would you do follow-up screening or testing?
I typically repeat the DEXA scan in about 2 years after initiation of medical treatment.
If it's stable or better, would you repeat it again?
Sorry, repeat that, it cut out.
If the DEXA is stable or better, would you repeat it again? Years.
I would repeat it again in 2 years to see if it's stable or not, and then consider decreasing the frequency of scanning.
All right, so you're going to repeat it in 2 years on therapy, and then you're going to repeat it 2 years again after that?
Yes.
Okay. All right, let's talk about this. So we would decide if we would take the patient's risks, as you said, and put her into the FRAX tool. What we would be looking for is a risk of fracture of 8.4%.
Okay.
It's 8.4 because that's the fracture risk for a 65-year-old. So we'd be saying this 58-year-old with her risks is the same risk for a fracture as a 65-year-old, which we know we would get one on a 65-year-old.
Yeah.
So you're right about the Z-score being age matched, and the T-score. T-score is looking at a patient between 30 and 35.
Okay.
A little bit older. Your minus 1.9 is low bone mass. So you would take that T-score, put it back into the FRAX tool with the patient's risks, and you would be looking for a result. And you said 3% or more of a hip fracture in the next 10 years, or a major osteoporotic fracture risk of 20% or more in the next 10 years. So if either one of those is positive, she would be a candidate for pharmacologic treatment. So the vitamin D for the 58-year-old would be 1,200, and the calcium would be 1,200, and the vitamin D would be 600 international units. So bisphosphonates inhibit osteoclasts, as you said. The contraindications, you said ulcerative disease, inability to swallow, mobility issues, all of which are correct. Hypocalcemia would be another. Renal disease or renal failure would be another. Severe GERD would be another. So We would repeat the DEXA in 2 years. If it's stable or better, we don't need to repeat it unless the patient develops new risk factors or we're going to stop the meds.
Okay.
And that would be to establish a new baseline. And then in terms of, so we would use a Z-score in two situations. If the patient's not responding to therapy, you could, if it's really low, you might consider working her up for secondary causes like hypoparathyroidism, thyroid disease, basically parathyroid disease, low calcium, low vitamin D. Would be the first thing to consider. The other time we would use a Z-score would be for somebody under the age of, let's say, 30 to 35, because their bone mass should be better than a 30 to 35-year-old. So if the score came back, let's say minus 0.8, you'd say, oh, she's fine, she's minus 0.8. Well, no, she should be in the positive category because she's closer to peak bone mass than that 30 to 35-year-old. Again, assuming the patient's, let's say, 25.
Okay.
Because peak bone mass occurs late teens.
Okay.
All right, very good. Thank you.
I do have a question. Is it necessary to initiate workup for secondary osteoporosis prior to starting bisphosphonates or any type of therapy for osteoporosis?
No, not unless there's other things that would make you suspicious.
Okay.
Very good. Thank you.
Okay. Thank you.
Sure. All right, we are going to try to get one more person in. Is Dr. Schleiser on? Don't see Dr. Schleiser. Okay. Dr. McEwen, are you on? Please raise your hand, guys, if you are a person we are calling on. Okay, no Dr. McEwen. Dr. Meyer? Is Dr. Meyer on? Ah, there she is. Hey,
Yep,
Melissa.
I'm here. Hi.
How you doing?
Good, how are you?
I'm doing well, thank you. Are you a generalist or specialist?
Generalist.
Okay, so what do we want to torment you with? Doesn't that sound exciting? Okay, how about a 47-year-old G2P2 having a hysterectomy for symptomatic fibroids? How would you counsel this patient regarding BSO?
Sure. So I would talk to the patient about her family history to determine if she has any family history of breast or ovarian cancers. And that's kind of where I would start with that counseling.
Okay, so let's say she doesn't report any patient with a history of breast or ovarian cancer. Are there other cancers that you would ask about family history-wise?
Breast, ovarian, colon, and then I would probably just ask about uterine as well. Any family history of that.
Okay. What would you be thinking of in the case of the colon and uterine?
Like a Lynch syndrome?
Does Lynch syndrome increase a patient's risk of ovarian cancer?
Actually don't know if I'm not sure if it does actually, but I'd have to look that up.
Okay, so you're gonna ask family history.
Yeah.
Let's say the family history is benign.
So typically I would tell the patient that if they're under the age of 50, I typically do not do ovary removal. I just do a bilateral salpingectomy. But I do always look at the ovaries, and if there's anything abnormal, I would of course be getting an ultrasound to look at that prior to the surgery.
So I'm a little confused. You said I do take a look if there's anything abnormal. I do look at the ovaries. If there's anything abnormal, then you said you get an ultrasound prior to the
Yeah, I was just kind of thinking back, just because we're already deciding to do that hysterectomy. So I'm just thinking back at my workup prior to surgery.
Okay. So let's say the ultrasound comes back as normal
Mhm.
from an ovarian standpoint.
Yeah.
So again, let's say the patient wants to have her ovaries out. She's like, "Doc, you got one chance here. I'm not coming back for surgery."
Yeah.
Would you take?
Sorry, go ahead.
No, would you take the ovaries?
I would counsel the patient that I would not recommend it at her age, given the increased risks of cardiovascular morbidity, increased risk of osteoporosis, cognitive function, and so it would not be recommended to do that in her case. And I would talk to her about those risks.
And I'm sorry, what age would you be okay with taking her ovaries?
So I started talking to people about it at age 50, kind of recommending it more at age like 53 to 55, but kind of around toward the age of menopause is when that would be more recommended, kind of globally.
How would you counsel her regarding the risk of reoperation by leaving her one or both ovaries?
Yeah, so there is a risk of reoperation. The overall risk is low. I don't know the exact number, but the risk is low.
Okay. What if you did take her ovaries out? Let's say you insisted on it. Would you take them out?
I would recommend not taking them out. One option that I could talk to her about is having a second opinion with one of my partners to kind of have somebody else to talk to her about those risks, just the fact that she is less than 50. If she was understanding of the risks and we had discussed like all the risks and benefits, I would consider it. But I think in these patients, it's also reasonable to get that person.
I'm sorry, would you do it or not?
I probably, I probably wouldn't if they were normal.
What are you going to do? She needs a hysterectomy.
If I had her see one of my partners and they had both kind of talked about it and she still very much desired it, I don't think I would want to, but yeah, I would want her to see one of my partners first, I guess is what I would say.
I'm sorry, what about your partners first?
I would want her to have that second opinion first.
Yeah, she had the second opinion. They said the same thing. She wants them out.
They said they would not do it?
They said they recommend that she keeps her ovaries, but she wants them out.
I would talk to the patient about patient autonomy as well and understanding of risks and benefits. If I would tell her that if we did take them out, I would recommend doing hormonal therapy, hormonal replacement therapy afterward. If she was completely understanding of all of those risks and we had talked about everything, I think then I would consider it if she had that second opinion as well.
I want to know a yes or no. Melissa, would you do it or not? Not consider it. I want to know if you would do it.
Yes, if she was understanding of all the risks and we talked about hormonal replacement therapy after.
Okay. Let's say she is 50, but she's not menopausal. Would you recommend hormone replacement therapy for that patient?
I would probably for about a year or two, just until the average age of menopause.
Okay. Now, what if she told you her mother went through menopause at 58? And the patient's 50 now.
Yeah, I typically still do it until the average age around like 51 to 52. But that would be a discussion. And if we stopped the hormone replacement, I would definitely see if she had any symptoms that would, but then we would talk about if we wanted to start them back, if she was developing menopausal symptoms and was doing it for more of a symptomatic standpoint.
So back to this 47-year-old for a second. So you said you would recommend hormone replacement for her. First of all, what would you put her on?
So if she had her uterus out, then I would do estrogen replacement alone.
Oral, transdermal, or vaginal?
I typically talk to patients about recommendation for transdermal would be my preference.
Why?
Because it avoids the first pass metabolism and can have a slightly decreased risk of VTE compared to the other forms.
So what risks would the transdermal estrogen that you prescribe, what would you tell her the risks are?
Yeah, so some increased risks of estrogen therapy. There can be slightly increased risks of VTE is what I would mainly counsel her about.
So increased risk of VT, any other increased risk?
Those are the main risks of estrogen alone that I would talk to her about.
Okay. What about the benefits?
Yeah, so there can be benefits including prevention of development of osteoporosis. There can be benefits, decreased colon cancer, and slightly decreased risk of breast cancer.
Decreased risk of breast cancer?
For estrogen alone.
Hang on one second. Okay, let's talk about this one.
Yep.
Family history. So I thought that was good. You said for breast and ovarian, then you added colon and endometrial. So Lynch does have an increased risk of ovarian cancer. In fact, if we consider the BRCA mutations as one mutation, so putting 1 and 2 together, Lynch would be the second leading genetic cause of ovarian cancer. So again, we're having to consider BRCA as one mutation as opposed to BRCA1 and BRCA2. Does that make sense? So yeah, you would want to know about the colon and endometrial cancer. Risk of reoperation if we don't take her ovaries out is about 5%. It's really 3 to 7%, depending whether she has one or both. And believe it or not, if she only has one ovary, it's in the 7s. If she has both, it's 3. That doesn't make sense. That's just the way it is. So I always suggest to candidates, they say, quote, about 5%. If you say less than 10%, you're fine as well. So the newer, I don't want to say they're official ACOG recommendations, but it wasn't an MOC article that we read. The newer recommendations seem to indicate that ovaries, whereas previously it was thought to be till age 65, had a benefit in terms of improving longevity. Now that age has probably it's been reanalyzed and it's probably more along the lines of like 53. So ACOG says you can discuss BSO with patients over 50. And you can discuss with patients 45 to 49, but if they do elect for BSO at that age, like this patient, you should offer and encourage hormone replacement, assuming there's no contraindication. Below 45, it should be discouraged. So my comment to you, Melissa, was I thought you were just the second opinion and all is good. If the patient had been 44, you kind of digging your heels in, so to speak, I would agree with you. My suggestion would be, advising, encouraging, but 45 to 50 or 45 to 49, again, recommending keeping their ovaries if everything looks good is fine, but I wouldn't make my Myers last stand or Custer's last stand on that.
Good. Yeah.
It was a little heavy hitting. It was like a 30-year-old saying, I want my ovaries out. I agree with you. I wouldn't do that either unless there's some reason.
Right. That makes sense.
So risks of hormone replacement. You said VTE, that's true. There's an increased risk of stroke in her 70s, so she'd have a good bit of time to worry about that. Improvement in osteoporosis or bone protection, yep. Vasomotor symptoms, yes, that would be improved with hormone replacement. Again, estrogen alone, you said transdermal, which was correct. You said reduction in colon cancer. That's not true. That's with estrogen and progesterone.
Okay.
You also mentioned decreased risk of breast cancer. Boy, I'd be real careful saying that.
Yeah.
in the Women's Health Initiative, it was close to statistically significant. The p-value was 0.06, and we use a p-value of 0.05. So in one fewer case of breast cancer, we would be saying it is protective. And there's certainly some studies that show, there's no increased risk, and maybe there are fewer risks, fewer cases. But I would not say that on the boards, because that would imply that you counsel patients, I'm going to put you on estrogen to reduce the risk of breast cancer.
That would have, yeah.
Which could lead to not a good score on the office section. So that's it. Do you have any questions?
No, that was helpful. Thank you.
Thanks for volunteering. Okay, so what I'm going to do now is I'm going to put everybody's hand down. If you have any questions, please do raise your hand if you want to ask them verbally. If you've typed them already in the box, that's fine. I'm going to go to those right now. What would you do if you have a retroperitoneal hematoma that is expanding, but you do not have access to GYN onc or vascular surgery? That's a great question. So what would we do? So, vascular surgery, you could call in a general surgeon. You certainly, in the short term, going to hold pressure on it. You're going to make sure that the patient is typed and crossed. So you're going to have anesthesia managing, her blood loss in terms of that. If you have any access to interventional radiology, you could certainly get them on board as well. But you're really going to have a tough time. I mean, obviously, if the patient's becoming unstable, it's really not recommended for generalists to go on the retroperitoneum in that situation. But I guess if the patient's completely unstable and the choice is letting her die or not, I mean, that would be a tough decision to have to make. Hopefully, anesthesia could keep up with the blood loss until you could get her or get somebody to come help. I would certainly mention calling in an extra obstetrician or calling in a general surgeon. And I would mention some of your thrombotic agents. If you do take the 50-year-old ovaries out, do you need to start on HRT for 1 year? So you don't need to start them on HRT. First of all, I would discuss it with them, though, in terms of offering it to them. If they're already menopausal, it's a moot point. Really, the question is, you have a 50-year-old and she's, not having any perimenopausal symptoms. I mean, geez, she might go another 4 or 5 years. So again, it's not wrong we certainly would offer the patient unless she has contraindications, in the case of taking her ovaries out before she's menopausal. In terms of recommendation, it would be very reasonable to recommend she keep her ovaries unless there's some compelling reason to remove them. But, and it's completely imprecise, but you certainly could ask, when family members went through menopause too, which might help guide you in terms of how long she stays on it. And there's nothing magical about 51. That is the correct age of menopause. And certainly for patients less than age 50, we would want to get them to that age 51 if we can. But if you're starting somebody, let's say at 50, let's say she's got symptoms, whatever, you don't have to stop them at 51. You could keep them going as well. But again, after 50, you don't have to. I would certainly offer it to the patient. 1, if she's symptomatic, and 2, if just in terms of explaining the pros and cons. When I put a premenopausal on HRT, if I performed an elective oophorectomy greater than 50, I think we just covered that. Two folks had the same question. Let's see, for estrogen alone, can I also say it decreases all-cause mortality? You can say that. What age do you outright recommend BSO with hysterectomy? So according to that reinterpretation and MOC article that came out, the answer would be 53, but we may have to confer with Bobby on that. And sorry, it's a Bobby's on the call, but it's a little bit of a, I don't say it's a private joke. I had to bring in the article for him. I don't think he believed me. Would you recommend HRT for someone who had a BSO for endometriosis? So again, certainly with, based on the age stuff that we were talking about, so under 50, yes. The question is, do you keep the patient off of HRT for, let's say, 6 months, like as if you were treating her with a GnRH medication and then start it, or do you start it straight away? Some of it's going to be dependent on how much residual endometriosis you think the patient has, but I would not start it because of her history of endometriosis. If she's symptomatic, also, you could consider putting her on a very low dose birth control pill, or even putting her on estrogen progesterone in the short term and then converting her just to an estrogen only pill, or estrogen only formulation for the hormone replacement. I get she's had a hysterectomy and doesn't need the progesterone, but I'm talking about to help suppress the endometriosis. Usually the low doses of estrogen that we put these folks on does not stimulate the endometriosis. And I've had patients like this in the past. I've tried to get them 6 months because I'm a 6-month believer, as if I were giving her Lupron. Depending on their age and the severity of their vasomotor symptoms, you may have some success, but I would argue even a couple, 3 months, in my opinion anyway, is going to benefit you. But there is no absolute right or wrong, like wait 6 months or not wait 6 months. Either is acceptable. So the short answer is yes, I would offer HRT to somebody who's had a BSO, even if they've had endometriosis. But again, I would try to wait a little bit of time. All right, took from the MOC article, age 50 is the recommendation, if I remember correctly. Were you saying it's a discussion of risk benefits? So age 50, they say you can certainly offer the BSO after age 50, but 53 it was actually one of the 8 questions we got asked if we read that article. At what age I think, did the benefits stop? And it was 53. So again, not saying you're wrong, you can offer at age 50, but again, it's an offer at age 50. It's not you should absolutely take the ovaries at 50. I think that might be it for questions. So let me see if anybody had any questions as their hand up. And if not, we'll let you guys disconnect, unless, of course, you have to go, in which case we'll let you disconnect anyway.
Mic on.
I do see one hand. Shakira, or Chikara.
Hello.
Hi.
Hi. Yes. I had a question about the DEXA scan. After treatment, when do you repeat it? I think I missed that.
Yeah, so you would want to repeat it 2 years after treatment, after you start treatment. And if it's stable or improved, you don't need to repeat it unless the patient develops new risk factors or you're going to stop the medication.
You said 2 years.
2 years.
Okay. And then I guess my next question was about the secondary causes, like when you screen for secondary causes, like after 2 years and they didn't improve, that's when you would look to see if there's a secondary cause?
Yeah, so there are 2 reasons to screen for secondary causes. Treatment failure would be one, assuming the patient's been compliant with the medication. And the other would be if the patient has a really low, again, they're negative numbers, so a very low Z score. Z as in zebra. So there's 2 times we would tip. Again, if somebody comes in and they're having symptoms of thyroid disorder, you could, you don't have to wait 2 years. If somebody lives in on the Montana-Canadian border or lives in Alaska and they're getting very little sunlight, half the year, again, they may be vitamin D deficient, as an example.
Got it.
Somebody who comes in and says, I don't eat any cheese, I don't drink milk, I'm lactose intolerant, and they're, I don't know, they're skimpy on the vegetables too. I eat red meat and meat and potatoes every night. Well, maybe that would be somebody you might want to check their calcium. And you might want to check, all their calcium is probably located in their coronary arteries, so maybe you ought to check that too. That's
okay. Sorry, and I guess that brings me to my third question, because I don't know how I missed all these, but the Z-score, who do you check those in, or what is that used for?
So again, the Z-score is useful for somebody if you're looking for somebody who's at risk for secondary causes.
Mm-hmm.
Z-score is also useful for somebody who's under the age of 30 to 35. Because a Z-score is age matched, and peak bone density occurs around 19 years of age. So if we have somebody that we think might have female athlete triad, let's say they're—
Or like a Turner's or something like that.
Well, I'm thinking actually, certainly could be that, but I'm thinking also somebody who is like a college athlete, let's say she's in her early 20s and she's exercising constantly, has low body fat, and is not keeping up with her caloric intake, based on her calorie expenditure. So we get a DEXA scan on her. If we use a T-score, her T-score should be in the positive territory, because her bones, because she's closer to peak bone age at, let's say she's 22 and peak bone age is 19. The T-score is looking at a 30 to 35-year-old. So at 22, her bones should be way better than the 30 to 35-year-old, right? So we would expect that T-score to be in the positive category, maybe +1. I'm making up the numbers, but definitely in the positive category. So if her T-score came back as 0, or let's say -0.5, so not low enough that we would be concerned with somebody that's older, but that would be very concerning, because she shouldn't be minus at all. She should be in the plus category. So we use a Z-score instead of a T-score to assess the patient's bone health.
Got it. For somebody her age. Okay, got it. Thank you.
My pleasure. Dr. Chen, you have your hand up. I'm not sure if you have another question. Yeah, I mean, if I did, it would be specified. So it's something that hasn't been classified one way or another. So unexplained, basically. Interesting question, though. Thank you. Kirby, I'm going to take you off mute. Were you good, Dr. Chen, or did you have another question? Dr. Kirby.
Yeah, this is more of a, I guess, a technique question. When I try and formulate a response to describe the WHI study, I feel like it gets very cumbersome and you can go in a lot of different directions. Do you have a recommendation or some style points about how to be succinct in describing that study in a way that is appropriate, I guess? Does that make sense?
Yeah, so, the study was done, as you know, and then it's been reanalyzed a million times, and there's a lot of flaws in that particular study. But I think the take-home message from the study, especially, with the reanalysis, is, estrogen progesterone itself is going to have an increased risk of, stroke in their 70s, cardiac events if given more than 10 years removed from menopause. And again, this is with Premarin and medroxyprogesterone acetate. If you're using prometrium, for example, there have been other studies that have shown that some of these risks go away. In fact, the breast cancer risks seem to go away with estrogen and micronized progesterone. But anyway, sticking to Women's Health Initiative, so there's 4 things that are increased. Blood clot in the legs, so VTE, cardiac if more than 10 years removed from menopause, breast cancer, one additional case per 1,000 after 5 to 7 years use, and stroke in their 70s. The 3 benefits of estrogen progesterone: vasomotor symptom decrease, osteoporosis or bone protection, and reduction in colon cancer. If we look at estrogen alone, We get the vasomotor and the bones for the benefits, and the only risks would be VTE and stroke in their 70s. The cardiac and breast cancer goes away. So they're similar. It's just that progesterone adds one benefit of colon cancer protection, but 2 additional risks in terms of breast cancer after 5 to 7 years and cardiac events if more than 10 years removed from menopause. That's about as succinct as I can make it.
Okay, no, that's helpful. Thank you so much. I'll probably have to re-listen and write all that back down, but the fact that you said it out loud is helpful.
Very good. Thank you.
Thank you.
Guys, we are way past time, so I don't know about you, but we got 2 more questions. I'm going to take these last 2 questions, and then we're going to wrap up. Jill?
Sorry, never mind. I'm good.
No, don't.
No. I had just pulled up the MOC article and I looked back at it because I had asked the question because I looked at the conclusion and it said age 50, but then I did see something else where it said like the intersection between it said plotting survival to age 80 years for those undergoing hysterectomy compared with hysterectomy and BSO, the intercept of the 2 lines crossed at age 53. Because in the conclusion of the article, it said 50. That's why I was confused.
Yeah, but did it say to recommend it at 50 or to offer it at 50?
I guess to offer it at 50. I mean, I didn't read the whole thing just now, but I read it like a few days ago. So I'm glad that you went over that.
Yeah, thank you. That was my recollection too, again, to offer it. And the 53 again, just because it was one of the 8 questions that was asked, what age would you recommend or whatever, or is there not thought to be a benefit beyond?
Mic off.
And that was the 53. All right,
Okay,
guys.
thank you so much.
Well, you've been a good group. Thank you all for your participation and good questions. I appreciate it. And thanks to our volunteers. I'm not sure when I have the next webinar with you, but it'll be coming up probably